You have primary syphilis, which is the lesion is single, painless, indurated, painless inguinal lymphadenopathy. So you have swollen lymph nodes that are painless. Diagnosis is confirmed by dark field examination. And we're going to talk about the syphilis testing is different than what you learned in the past, and that's a money thing, and we'll discuss that. VDRL is negative. Secondary syphilis is rash, arthritis, hepatitis, and nephrotic syndrome. Condyloma latae, which is, what is that? Condyloma latae is a raised, flat, topped, or cauliflower-shaped lesions. Patient can have aseptic meningitis, generalized lymphadenopathy. Latent is a presence of serological diagnosis, but without the clinical symptoms. It can be early latent, less than 1 year, or late latent, greater than 1 year, based on when the patient was infected. Sometimes you don't know when they're infected because they can't remember, or they just kind of walk through it and didn't think about it. IM penicillin G, 2.4 million units. IM times 3 doses weekly for late latent. Early latent, the same as primary and or secondary. Early syphilis. Treatment is doxycycline, 100 milligrams PO for 14 days, or ceftriaxone 1 gram IM or IV for 10 to 14 days. These are alternatives to penicillin, benzathine penicillin. Penicillin is great. There really is no cases of resistance. This was a game changer. Penicillin was a game changer. Syphilis was the HIV back in the day. It was the COVID-19 back in the day. There were residency programs. They weren't resident at that time, but there were programs, or you were a doctor of syphilis back in the day, because syphilis affected the whole body. This was the pandemic back then. Post-exposure prophylaxis can be 200 milligrams doxycycline for men who have sex with men and transgender women, yielding a 73% reduction in syphilis. Now, we're starting to get questions on post-exposure doxycycline, the side effects and resistance. These are things that we'll talk about. We'll see if this is going to continue in the future. Erythromycin should not be used. Resistance is high. Secondary syphilis, systemic illness with generalized macular and papular rash on the trunk, extremities, including when you start seeing things on the palms of soles, start thinking about syphilis. Can also see condyloma latae, which is going to be those raised cauliflower-like lesions. Fever and generalized lymphadenopathy can be common. Treatment is benzathine penicillin, 2.4 million units IM, or 1 dose of doxycycline, 100 milligrams PO BID for 14 days. Go into tertiary syphilis. A gamma can be seen. These are soft, non-cancerous growth resulting from the tertiary stage of syphilis. It's a form of a granuloma. Cardiovascular, remember, this can affect the whole body. You have aortitis, aortic regurgitation, aneurysm, aortic aneurysm, because the syphilis hits the vasovasorum. Remember, the vasovasorum is the blood supply for the aorta. You can have coronary osteostenosis. CNS can have meningovascular. 5 to 10 years after infection, you can have CVAs, encephalitis. Generalized paralysis, 20 years after infection. Can affect the personality, reflexes, eye, intelligence, speech. Let's go back real quick. So what can we use in non-pregnant penicillin allergic patients? Alternatives include, we talked about doxycycline, 100 milligrams PO daily for 14 days, tetracycline, 500 milligrams orally 5 times a day, ceftriaxone 1 gram IV intramuscular daily for 10 days. All right, continued discussion on syphilis. Talking about tabellus dorsalis, can happen 25 to 30 years after infection. We have ataxia, wide-based gait, paresthesia, bladder disturbances, impotence, areflexia, loss of position, deep pain, and temperature sensation. Can have demyelination of the posterior column, dorsal roots, or dorsal root ganglion. Can have cardiovascular side effects and neurosyphilis, which can be asymptomatic to ocular can have these severe ranges, everything from asymptomatic to ocular and to meningeal vascular disease. Treatment, aqueous crystal and penicillin, these huge doses. It's going to be 18 to 24 million units given in 3 to 4 million units, Q4 hours, continuous IV drip for 10 to 14 days, or ceftriaxone 2 grams IM IV for 10 to 14 days. Syphilis diagnosis, indications of spinal tap, positive neurological signs and symptoms, RPR or VRDL, titer is greater than or equal to 1 to 132. Treatment failure, or if they're HIV positive with a CD4 count less than 350. CSF findings, increased protein, increased cell, lymphocyte, VDR, specific but not sensitive. FTA, ABS, sensitive but not specific, negative FTA, ABS testing on CSF, rule out neurosyphilis, monitor CSF count every 6 months until normal. If VDR is positive and VFTA and ABS is negative, false positive. We're going to talk more about the testing. Serology, RPR and VRDL is a non-troponin test recommended for screening for measurement of the serum antibody following titers after treatment. Troponin tests can be fluorescent troponin antibody absorption, FTA, ABS, troponin palladium particle aggregation assays, the TPPA, used for confirmation to confirm results from non-troponin tests. Results remain positive after treatment. Treatment here again is going to be benzothioxine 2.4, benzothioxine G 2.4 million units IM times 1 dose, or doxycycline 100 milligrams POBID for 14 days. All right, let's go back to our shift in testing for syphilis. It's changed. So prior you used the RPR or VRDL, was a non-troponin testing first. Then if positive, you went to the confirmatory test, was a troponin test, was the FTA, ABS was then performed. Now this reverse, and rapid troponin testing is done first. The algorithm is reversed because there's an automated and rapid troponin testing. So first you do the troponin testing, so you would do the automated FTA, ABS. Then if positive, then you would go to the RPR or VDRL. There are also now point-of-care testing for troponin and non-troponin antibodies. So the world is changing, and the testing is getting faster and cheaper. Patients having a Herxheimer reaction. It's a rash consistent with secondary syphilis after the patient is being treated with penicillin, then develops fever, malaise, and headache. The dying spirochetes releasing antigens. The lipoproteins released from the treatment of troponin palladium infections are believed to be Herxheimer reaction. Reaction shows an increased inflammatory cytokines during the period of exacerbation, including we're going to have increased tumor necrosis factor alpha, interleukin 6. Interleukin 6 is everywhere. We're seeing a lot of this. This is going to be the key for treating these infections and even chronic infections too. Interleukin 8. What do? Do not stop the treatment. Give supportive care. And possibly consider giving aspirin. All right, this is an 87-year-old female with past medical history of CHF, gets an asymptomatic UTI. So let's talk about this. Gets an antibiotic. So let's go back to the statement again. 87-year-old female with past medical history of CHF. This is one of those real-world stories that just kind of hurts you when you go through it, because this is a true story. 87-year-old female with past medical history of CHF has an asymptomatic UTI and then gets an antibiotic. Should she have gotten the antibiotic? Probably not. She codes. She recovers. After the code, we get the labs. She has extreme hypokalemia. So let's talk about this. As women age, several factors increase their susceptibility to urinary tract infections. These include decreased estrogen levels, they weaken the pelvic floor muscles, and have a higher higher likelihood of underlying health conditions, possibly more medications, immunosuppression. So what's going on? What antibiotic did she get? So she gets an antibiotic, gets hyperkalemia, and then codes. Now let's go back to this lady too. This young lady at 87 has CHF. She was on a diuretic, and she also had received what? She received potassium because she's had hypokalemia constantly. And then she receives an antibiotic. That antibiotic with trimethoprim sulfaminazole, which is common, can be given, but what happened is she had hyperkalemia, and she was still taking the potassium. She had acute kidney injury because of the fact of the trimethoprim sulfaminazole. It was the fact is that she was not eating or drinking well, and she had an extreme hyperkalemia. It came with a potassium of 9. So I know this is a lot. The potassium, it gets elevated when taking trimethoprim sulfaminazole because of the effects by blocking the amyloid sensitive chloride channels in the cortical collecting duct. What are some other side effects of trimethoprim sulfaminazole? You can have pancytopenia and the high risk for Stevens-Johnson syndrome, but that can be in anybody, any antibiotics that we get. So let's talk about this again. 87-year-old female. She gets a regular checkup. During a regular checkup, she noted for a UTI on labs. She also said that she was tired, so they attributed this to the UTI. She gets an antibiotic. The antibiotic was trimethoprim sulfaminazole. She codes. The code was related to her hyperkalemia from the side effect of the trimethoprim sulfaminazole. So just think about all these things. She continued to take her potassium. She had potassium shot up to 9. All these things are, this is a real world scenario. And for a while we had a bunch of these coming in because somebody was loving the heck out of trimethoprim sulfaminazole for their older patients. And all these older patients happen to have a lot of potassium and taking a lot of potassium because in the history of hypokalemia, this was reversed rapidly and they coded. Here's an example. Look at this right here. This is a peak T wave. See this right here, this peak T wave. You can have a widening of the QRS complex. You can see this better right here. And what happens is then they get peak T waves, widening QRS, and this lady went into VTAC, VFib. All right, let's talk about urinary tract infections. This is a broad term involving infection that can occur anywhere in the tract, including urethra, bladder, ureters, and kidney. Major risk factors are female sex, postmenopausal women, as we talked about, decreased amount of estrogen, weakens the pelvic floor. In previous UTI, E. coli is the most common organism, but you can have Klebsiella proteus, Cephalitis, and Pseudomonas. Candida infection in those who have diabetes or indwelling catheters. The complicated UTI is an infection with comorbidities or anatomical abnormalities of the tract. They have increased risk of adverse outcomes and poor response to therapy or resistant organisms. Complicated UTI, any of these listed. Poorly controlled diabetes mellitus. Pregnancy, very important pregnancy, they need to be treated right away. There is no asymptomatic in pregnancy. Hospital-acquired infection. Acute kidney injury or chronic kidney disease, suspected or known urinary tract obstruction. In gentlemen, this could be what? BPH or a urethral stricture. Presence of an indwelling urethral catheter, stent, neuropathy tube, or urinary diversion. Functional or anatomical abnormality of the urinary tract. These are your complicated UTIs. Renal transplantation or other immunocompromising condition. Urinary tract infection diagnosis. Dipstick to assess for pyuria and bacteria via leukocyte esterase and nitrates. False negative for nitrates can be a non-converting organism or low pH. Let's go back to that real quick. Urine culture should be obtained in all pregnant women during the first trimester of pregnancy to screen for asymptomatic bacteria in patients undergoing urological procedures. Patients with infection usually have a 10 to the 5th colony-forming units on culture. Absence of pyuria in symptomatic patients should prompt consideration of an alternative diagnosis, meaning that if there is absence of pyuria in symptomatic patients, there's something else going on. All right, let's talk more about UTI management. Asymptomatic bacteria is the presence of bacteria on 2 consecutive voids with isolation of the same strain, greater than 10 to the 5th colony forming units in women, and in single void in males. So it's asymptomatic. Pregnant women we would treat, we would not treat, and other individuals we would not treat. Treatment is only in pregnancy in those undergoing urological procedures. If they have neutropenia, renal transplant, or urinary obstruction, those are the patients that we consider treating. Cystitis, most common symptoms for women: dysuria, frequency, urgency, and suprapubic discomfort. This is going to be infection of the bladder. Hematuria are the most common symptoms in postmenopausal women. Fever is usually not present. Organisms can be E. coli and other gram-negative rods, Staphylococcus, Enterococci. All right, let's talk about cystitis treatment. First line is going to be nitrofurantoin for 5 days. Nitrofurantoin is given out like water. It does have side effects, and you need to look at the resistance pattern in your area. It can have side effects where it has a reaction with medications with antacids containing magnesium trisalicylate. If you use long-term, it can cause interstitial lung disease and pulmonary fibrosis. So patient coming in has been using nitrofurantoin for a period of time, goes to a pulmonary clinic, can have pulmonary fibrosis with long-term use. Also can develop peripheral neuropathy and optic neuritis, or trimethoprim sulfametazole, which we've talked about the side effect, and can have hyperkalemia. Or fosfomycin, 3 grams PO, can be given once. Trimethoprim sulfametazole should not be used if it's been taken in the last 3 months, is there can be greater than a 20% resistance in the community. Short-term regimen can be 1 tab PO Q day for 5 days can be recommended. Fluoroquinolones and beta-lactams are second-line therapy, and there's increasing resistance. Remember, fluoroquinolones, we talked about the side effects of those, and the side effects can be big, including increased risk of ESBL, can cause altered mental status, especially in the elderly. In pregnancy, 7-day course of amoxicillin clavulanic acid, nitrofurantoin, or cefoxitin, cefazine, or fosfomycin, 3 grams single dose.